The title of this lecture is Hypertension Guidelines and Protocols, Uses and Challenges. I'm Dr. Hind Beiry, Associate Professor of Physiology at International University of Africa, Sudan. The outline of the presentation will be the introduction, definitions, uses, challenges, and conclusions. Raised blood pressure remains the leading cause of death globally, accounting for 10.4 million deaths per year. However, blood pressure trends show a clear shift of the highest blood pressure from high income to low income regions, with an estimated 349 million with hypertension in high income company and 1.04 billion in low middle income countries. Hypertension is a primary care problem, which is therefore best detected, managed, and followed up at primary care level by a primary care team led by a physician. The accompanying implementation tools are in the form of a quick reference guide, algorithm, patient information leaflet, and quality standards. Hypertension protocol is a predetermined written physician-authorized procedures for medical care and management of hypertension based on patient presentation. It consists of a combination of lifestyle modifications and of drug therapy. Drugs include ACE inhibitors, calcium channel blockers, ARBs, B blockers, and thiazide diuretics either alone or in combination. The benefit of treatment is related to reduction of blood pressure and cardiovascular risk rather than the use of a particular drug. Hypertension guidelines. It is a medical written document with the aim of guiding decisions and criteria regarding diagnosis, management, and treatment of hypertension. The published hypertension guidelines are evidence-based and declare combined consensus-based recommendations to address areas of uncertainty. Most guidelines are national in scope, like NICE, JNC8, Canadian Hypertension Education Program, Australian, while others are focused on a wider regional or international audience. European Society of Hypertension Guidelines, American Society of Hypertension, and International Society of Hypertension. Where the ISH Global Hypertension Practice Guidelines 2020 were developed by the ISH Hypertension Guidelines Committee based on evidence criteria to be used globally to be fit for application in low and high resource settings by advising on essential and optimal standards, and to be concise, simplified, and easy to use. In accordance with most major guidelines, it is recommended that hypertension be diagnosed when a person's systolic blood pressure in the office or clinic is equal or more than 140 millimeters mercury, and or their diastolic blood pressure is equal or more than 90 millimeters mercury following repeated measurements. The established blood pressure measurement method is office blood pressure measurement, ambulatory blood pressure monitoring, home blood pressure monitoring. The office attended is the oscillatory mercury aneroid oscillometer and the electronic. How to measure the blood pressure? 7 simple tips to get on an accurate reading. First tip is cuff on bare arm over close at 5 to 50 millimeter. Correct cuff size, too small, at 2 to 1 millimeter mercury. Don't talk, distracting with conversation adds 10 millimeter mercury. Support arm, unsupported adds 10 millimeter mercury. Legs uncrossed, crossed legs adds. Support back feet, unsupported also adds. Empty bladder, full bladder adds 10 millimeter mercury. Correct position to measure the blood pressure. The back is supported, straight, no talking during and between measurements. Cuff to fit arm size, small, usual, large. Arm bare and resting, mid-arm at heart level. Quiet room, comfortable, temperature, no smoking, no coffee, no exercise for 30 minutes, empty bladder, relax for 3 to 5 minutes, take 3 measurements at 1 minute intervals. Use the average of the last 2 measurements. Patient preparation, here is also a demonstration of how the blood pressure can be measured. Selection criteria for blood pressure, cuff size for measurement of blood pressure in adults, arm circumference, 22-26 centimeters will be a small adult, usual cuff size, 27 to 37 centimeters is the adult, usual cuff size, 35 to 44 large adult, 45 to 52 adult thigh. Blood pressure definition, systolic blood pressure. First, cough sound. Diastolic blood pressure, fifth cough sound. Pulse pressure, systolic blood pressure minus diastolic blood pressure. The mean arterial pressure is the diastolic blood pressure plus 1/3 pulse pressure. And mid-blood pressure, sum of systolic blood pressure and diastolic blood pressure, and divide by 2. The International Society of Hypertension 2020, there is the classification of hypertension based on office blood pressure measurement. Category, the systolic and the diastolic in millimeter mercury. The normal blood pressure, less than 130, the systolic blood pressure, millimeter mercury, and the diastolic less than 85 millimeter mercury. High to normal blood pressure, systolic blood pressure is 130 to 139 millimeter mercury, and or diastolic blood pressure 85 to 89 millimeter mercury, the diastolic. Grade 1 hypertension is 140 to 159 millimeter mercury, the systolic blood pressure, and the diastolic from 90 to 99 millimeter mercury, and or. Grade 2 hypertension more than or equal to 160 and or diastolic blood pressure more than or equal to 100. International Society of Hypertension diagnostic blood pressure thresholds, the location and the threshold in millimeter mercury. The office, 140 over 90. Home, 135 over 85. 24 ambulatory monitoring, 24-hour average, 130 over 80. Daytime average, 135 over 85. Nighttime average, 120 over 70 millimeter mercury. High normal blood pressure is intended to identify individuals who could benefit from lifestyle interventions and who would receive pharmacological treatment if compelling indications are present. Isolated systolic hypertension, defined as elevated systolic blood pressure equal or more than 140 millimeter mercury and low diastolic blood pressure less than 90 millimeter mercury, is common in young and in elderly people. In young individuals, including children, adolescents, and young adults, isolated systolic hypertension is the most common form of essential hypertension. However, It is also particularly common in the elderly, in whom it reflects stiffening of the large arteries with an increase in pulse pressure, difference between systolic and diastolic blood pressure. Individuals identified with confirmed hypertension, grade 1 and grade 2, should receive appropriate pharmacological treatment. Hypertension diagnosis, out of office blood pressure measurement. Out of office blood pressure measurement is often necessary for the accurate diagnosis of hypertension and for treatment decisions. In untreated or treated subjects with office blood pressure classified as high normal blood pressure or grade 1 hypertension, systolic 130 to 159 millimeter mercury, and or diastolic 85 to 99 millimeter mercury, the blood pressure level needs to be confirmed using home or ambulatory blood pressure monitoring. The use of office and out of office home or ambulatory blood pressure measurements indicates subjects with white coat hypertension and those with masked hypertension. White coat hypertension, elevated blood pressure only in the office, non-elevated ambulatory or home blood pressure. Masked hypertension, non-elevated blood pressure in the office but elevated blood pressure out of the office, ambulatory or home. These conditions are common among both untreated subjects and those treated for hypertension. About 10 to 30% of subjects attending the clinics due to high blood pressure have white coat hypertension, and 10 to 15% have masked hypertension. Blood pressure measurement plan according to office blood pressure levels. Office blood pressure levels in millimeter mercury less than 130/85. This indicates remeasure within 3 years, 1 year in those with other risk factors. Blood pressure levels 130/159/85 to 99 millimeter mercury, if possible, confirmed with out-of-office blood pressure measurement, high possibility of white coat or masked hypertension. Alternatively, confirmed with repeated office visits. The blood pressure more than 160/100 confirmed within a few days or weeks. Personal history of cardiovascular diseases, myocardial infarction, heart failure, stroke, transient ischemic attacks, diabetes, dyslipidemia, chronic kidney disease, smoking status, diet, alcohol intake, physical activity, psychosocial aspects, history of depression, and family history of hypertension, premature cardiovascular disease, familial hypercholesteremia, and diabetes are all risk factors. Assessment of the newly discovered cases, assessment of overall cardiovascular risk in line with local guidelines, recommendations, symptoms and signs of hypertension, coexistent diseases, chest pain, shortness of breath, palpitations, claudication, peripheral edema, blurred vision, headache, nocturia, hematuria, dizziness, secondary hypertension as well. 10% of all cases are due to secondary hypertension. The guidelines enable a systematic, cost-effective approach to the screening, detection, evaluation, and management of hypertension. Emphasize a public health approach to hypertension, which predicts population-based strategies which could decrease the burden of hypertension. Aid awareness and better control of high blood pressure. Guide local initiatives in order to motivate policy changes and serve as an instrument to drive local improvements in standards of care of hypertension. The population-based strategies permit increased detection of hypertension by non-physician staff, education of the patient to improve outcomes of treatment, use of cost-effective diagnostic tools, and a core list of efficacious, safe, and economical antihypertensive drugs. Suggestions of systemic mechanism to maintain adherence. Empowerment of health care providers, especially those in primary care, to manage hypertension. The guidelines are intended for use by the healthcare providers, patients, and administrators. The guideline has a primary care focus and a public health approach. The focus on primary care is crucial since our biggest challenge is that the majority of hypertensive patients are undiagnosed because of the asymptomatic nature of the disease. Increased detection of hypertension can only be accomplished by a sustained effort to measure blood pressure in adults at a clinic or by a nearby healthcare providers. Evidence of the potential of community health workers to effectively contribute to control and management of non-communicable diseases is emerging from a number of low and middle income countries. The challenges of the ISH guidelines are hypertension control. It still remains a largely unmet challenge for public health systems. Despite the progress in blood pressure measurement techniques and the availability of effective and safe antihypertensive drugs, a large number of hypertensive patients are not properly identified. Also, a significant proportion of those who receive antihypertensive treatment fail to achieve satisfactory control of their blood pressure levels. Global hypertension disparities are substantial and continue to increase. When comparing high-income countries with low, moderate income countries from 2000 to 2010, the proportions of awareness, treatment, and control improved by more or less than 10% in high-income countries. In low and middle-income countries, however, improvements were limited for awareness, 32.3% up to 37.9%, and treatment 24.9% up to 29.0%, and even slightly declined for control, 8.4% to 7.7%. A recent analysis of individual level data from 1.1 million adults in nationally representative samples in 44 low middle income countries reports that among those with hypertension, 26% had never had their blood pressure measured, 39% had been diagnosed with hypertension before the survey, 30% had been treated, and only 10% had achieved control of their blood pressure, of their hypertension. The best hypertension care performance was found in Latin America and the Caribbean, whereas countries in the sub-Saharan Africa tended to show the poorest performance. The first significant barriers to address in low middle income countries is exceptionally poor awareness. May measurement months, the Lancet Commission of Hypertension proposed that every adult should know their blood pressure, a critically important starting point. In response to this call, the ISH launched a global blood pressure measurement awareness campaign, namely May Measurement Month, screening more than 4.2 million adults from 2017 to 2019. In 2019, 92 countries participated, and of the 1.5 million screens, one-third had never had a blood pressure measurement taken before. It is difficult to comprehend that a blood pressure measurement, which is arguably the cheapest, easiest, and the most essential first step and convenient method to assess cardiovascular risks is still not widely implemented. With hypertension control rates of 10% in low middle income countries and with significant population boom occurring among many low middle income countries, there is a need for radical improvement in detection and treatment strategies. Resource setting depends largely on cost consideration. A recent review of economic evaluation of hypertension treatment programs across 15 low-income countries found hypertension control to be a highly cost-effective intervention. However, there are apparent gaps in evidence on critical program elements to improve the cost effectiveness. This includes task-sharing strategies and standardized treatment protocol. In response to that, over 3/4 of heart disease and stroke-related death occur in low-middle-income countries. The WHO and the U.S. Centers for Disease Control and Prevention launched the Global Heart Initiatives. In partnership with several global organizations such as the American Heart Association, ISH, and Resolve to Save Lives, the Heart's technical package was developed with modules spanning healthy hypertension guidelines targeting low-middle income countries, healthy lifestyle counseling, evidence-based treatment protocols, access to essential medicines and technology, risk-based cardiovascular disease management, team-based care, and systems for monitoring. This package is intended for use by policymakers and program managers within ministries of health and resource-limited settings, with availability in several languages, and implementation of the package should be promoted widely. Take-home message: guidelines areas that concern non-physician screening and diagnosing hypertension, accurate blood pressure measurement during screening and follow-up so as to reduce the global burden of raised blood pressure. B, updates of blood pressure classification, identification of cardiovascular risk factors and signs of hypertension-mediated organ damage, assessment of compliance and medications, initiation of lifestyle management. Challenges: lack of proper equipment for blood pressure measurement, especially electronic devices and ambulatory blood pressure measurement, difficult access to rural areas to screen for hypertension, presence of political and military challenges in conflict-ridden areas. More challenges: more attention should be given to the role of ambulatory and home blood pressure monitoring, blood pressure telemonitoring, and mobile health technologies. These may allow not only to quantify different blood pressure patterns known to have prognostic relevance, such as nocturnal dipping, but also to improve adherence to medication. In order to be correctly used, the hypertension protocols are expected to be clear and easily implemented. Low and middle income countries often follow the release of guidelines from high-income regions closely, as their resources and health systems to develop and implement local guidelines remain challenging. Challenges in the use of protocols following the guidelines from high-income regions are sometimes impractical. This is because low-resource settings face a substantial number of obstacles, including severe lack of trained healthcare professionals, unreliable electricity in rural clinics, low access to basic office blood pressure devices, and limited ability to conduct basic recommended diagnostic procedures, and poor access to affordable, high-quality medications. Thank you very much.